Hello and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Quinn.
And we're back to move onwards from the GU subject to move into a few miscellaneous topics. And today we're going to be talking about hepatocellular carcinoma.
We apologize for the delay between episodes. We've been trying to keep to our every other week schedule, although we added another member to the Ryan and Ryan family recently and got a little off track. 2 kids, a lot of work. We are quickly learning.
We're happy to be back and certainly talking about a topic that I find very exciting due to the fact that hepatocellular carcinoma is a unique malignancy among many that we've discussed, such that a lot of the approach is initially dictated by local regional therapies, and there's many options in the local regional setting between interventional radiology, surgery, and radiation oncology, with medical oncology historically having a very minimal impact. However, over the last 10 years, there's been increasingly new and effective systemic therapy options for hepatocellular carcinoma, so we're becoming increasingly involved in what is truly a multidisciplinary disease site.
So hepatocellular carcinoma is the most common primary tumor of the liver, with the second being cholangiocarcinoma. And it's always important to distinguish between these two prior to treatment. This is a more common disease globally, and it's actually the 4th leading cause of cancer death worldwide. Hepatocellular carcinoma does have a pretty poor prognosis, with a 5-year overall survival of about 20%. Many of these patients have underlying comorbidities and liver failure or liver disease when they're first presenting, as well as the fact that many patients present with metastatic disease. Basically, cirrhosis from any cause is a risk factor for developing HCC. This can be from viral etiologies such as hepatitis B or C, alcohol, obesity such as non-alcoholic fatty liver disease, as well as other causes of cirrhosis such as iron overload from chronic transfusions, hereditary hemochromatosis, alpha-1 antitrypsin deficiency, acute intermittent porphyria, and Wilson's disease.
In the case of viral hepatitis, we don't necessarily need to develop cirrhosis. From a treatment standpoint, this is a challenging disease historically, as it has been chemotherapy insensitive for the most part. Complicating the management also is that many of these patients have cirrhosis, and cirrhosis is a very complex syndrome to have, leading to risks of bleeding, thrombosis, infection susceptibility, as well as the risk for ascites and decompensation. Fortunately, we've been able to see in some settings a reduced rate of development of disease, and at least one study in Taiwan has shown that vaccination to hepatitis B had dramatically reduced the rate of liver cancer being diagnosed from 0.5 patients per 100,000 to 0.2 patients per 100,000 population. Hopefully, as increased access to hepatitis B vaccination increases, as well as increased treatment for hepatitis C, we'll continue to see viral-related HCC. Unfortunately, globally, especially in the Western world, the obesity epidemic has led to a gradual increase in non-viral HCC, and the prevention of this will require much more complicated interventions. For patients who have a history of hepatitis or a known history of cirrhosis, there is evidence that screening can help identify hepatocellular carcinoma in an earlier state. This is thought to be desirable because when localized, we have more treatment options available. The evidence for screening for HCC is fairly poor, and there's been no data showing that this actually improves overall survival. That being said, this is a much easier disease to treat locally, and in patients with cirrhosis, most guidelines would suggest some form of liver imaging on an annual basis, typically with a right upper quadrant ultrasound.
Even with the recommendations to do screening for patients with cirrhosis, many people end up presenting with the cancer at a later stage. This can present with signs and symptoms of liver disease, and when you do imaging to work this up, finding a new liver mass. People can also present with abdominal pain, weight loss, as well as a palpable mass or firm liver on exam.
Generally, if the disease is symptomatic, we're going to presume this is a more advanced tumor. When it is caught in an earlier setting, it's going to be either caught by screening or incidentally when someone's getting imaging for some other purpose.
There are a few paraneoplastic syndromes that are associated with HCC, such as hypoglycemia, erythrocytosis, and hypercalcemia.
If a liver mass is identified, it's actually possible to confirm a diagnosis of hepatocellular carcinoma without performing a biopsy. This is a bit unique to all the cancers we've looked at in our previous discussions. There's guidelines that say in any patient with cirrhosis, a lesion greater than 2 centimeters, elevated AFP, and characteristic findings of hepatocellular carcinoma, we can confirm a diagnosis without a biopsy.
An important thing to note with this is that it has to be a high-risk patient. So if someone doesn't have an underlying history of liver disease or high risk for HCC, these imaging features would still require a biopsy. The imaging that's used is usually either a triple phase CT, with triple phase meaning the late arterial phase, portal venous phase, and the delayed phase after the contrast has left. And this can also be diagnosed on a liver MRI. Now, it's important when you're suspecting HCC to specify to radiology that that's what you're looking for, because you need to make sure that the scan is protocoled for this. The characteristic features are arterial enhancement with venous washout.
Another buzzword that could show up would be a pseudocapsule at the time of venous washout, which means that there's just a light rim of enhancement at the outer edges of the tumor. This pattern of arterial uptake and venous washout is unique to other incidental masses seen in the liver. For example, hepatic hemangioma might have arterial uptake because it's a blood vessel-filled mass. However, due to the fact that this has so many blood vessels, it does not have the venous washout. Conversely, a hepatic cyst won't have arterial enhancement in the first place. Historically, there's concerns for safety of liver biopsies due to the risk of bleeding or even the concern of needle tract seeding, which means that when we put the needle in to biopsy the mass, when we retract it, we're actually leaving some cancer cells behind. Although these risks are real, they're probably a lot less than what was previously thought, with risks of bleeding in modern studies estimated approximately 0.4%, and needle tract seeding at approximately 1.5%. We would still offer a biopsy if necessary. For tumors that are surgically resectable, deemed highly suspicious, you may consider just doing a full surgical resection rather than proceeding this with a biopsy.
Now, our radiology colleagues have come up with a way of standardizing the reporting, which is very helpful to us. And this is called the LIRADS criteria, the Liver Imaging Reporting and Data System. That's what LIRADS stands for, similar to the BIRAD system for breast cancer. And now this can really only be applied to patients, again, with a history of liver disease and with risk factors for HCC. You can use these criteria to help decide if you need a biopsy. And it's scored from 1 to 5, with 1 being the lowest probability of HCC and 5 being the highest probability. Now, for patients with the LIRADS 5, that's definite HCC, and there's really no need to biopsy in this case. For LIRADS 1, 2, or 3, usually what's recommended is some sort of surveillance because this is considered low risk. And the LIRADS 4 is when we really want to have a multidisciplinary discussion regarding the suspicion and the need for biopsy.
Once you've diagnosed a hepatocellular carcinoma, as with all cancers, the next step comes to staging. There's various staging criteria out there. The AJCC, which is the most common staging criteria we've talked about in the past, is probably the most accurate in terms of prognosis for hepatocellular carcinoma, especially in later stages of disease. But the most commonly seen staging criteria that's used to direct management, especially in the earlier stages, and often for clinical trial enrollment, is the Barcelona Clinic Liver Cancer System. And this staging criteria uses A, B, C, D guidelines as far as the best way to manage, which are quite detailed, especially in the A and B stage. Now, as our discussions are primarily medical oncology, we're not going to go into too much detail about all of the different interventional radiology and radiation oncology approaches, but it's good to be aware of those that are out there, and we'll get to those in a moment. But I'll just briefly highlight those in context of the staging criteria here. So for stage A, this would refer to a single hepatocellular carcinoma tumor or 3 tumors that are all less than or equal to 3 centimeters. For a single lesion, a surgical resection or regional ablation may be considered. Another option for these patients, especially in those with multifocal tumors, would actually be considered doing a full liver transplant, which can be curative in carefully selected patients. Most patients with stage A have a median overall survival of greater than or equal to 5 years. Stage B disease refers to multiple nodules, and this would typically be treated with local therapy such as TACE, transarterial chemoembolization, TARE, transarterial radioembolization, or transplant if possible. For multiple nodules that are diffuse and the patient's not eligible for transplant, then stage B could even be a patient that's treated with systemic therapy. For both stage A and stage B, there should be no invasion of the tumor into any of the vasculature. Portal vein invasion or major hepatic vein invasion are very poor prognosis, and the presence of either of these would make you stage C. Patients with stage C disease have to, by definition, be child PUA or child PUB and have a good functional status. Stage C also includes patients with disease that has spread outside of the liver. In this case, case, the median overall survival is approximately 2 years, and the standard of care should be systemic therapy. Stage D refers to patients with Child-Pugh C disease or proforma status of stage 3 or 4. Essentially, these are patients with decompensated liver failure. Prognosis here is less than 3 months, and best supportive care would be considered standard of care.
So as you can see, while the staging of the cancer is important, it's almost more important to determine the baseline liver function, because that really is going to decide what treatment is appropriate.
Probably the most commonly used liver function criteria is the Child-Pugh score. This is a score that goes anywhere from 5 to 15 and is subcategorized into A, B, or C, with A being 5 or 6, B being 7 to 9, and C being anything greater than equal to 10. The Child-Pugh score incorporates 3 lab criteria and 2 exam criteria. The lab criteria are elevated bilirubin, reduced albumin, or elevated INR, and the exam criteria are hepatic encephalopathy and ascites. All of these have a 1 to 3 scoring system depending on the degree of abnormality. And once again, for Child-Pugh A, we're going to have a lot of options that we're going to be considering. Child-Pugh B, we're going to be restricted, and often these patients are excluded from clinical trials, but may be treated in practice. And Child-Pugh C, once again, being a very poor prognosis, and in the absence of reversible etiologies, should be treated with best supportive care.
Now, with the exception of patients with obvious metastatic disease, many of these patients will have a multidisciplinary evaluation to determine if local regional therapy is appropriate. These patients should be seen in high-volume centers that have access to these interventional radiology or radiation oncology techniques. Now, if the tumor is deemed resectable and the patient has the patient would have good residual liver function, then surgical resection would be the recommended treatment.
Can certainly be a curative approach. However, there are some high-risk features such as tumors greater than 5 centimeters, 3 or greater tumors, evidence of vascular invasion, grade 3 or 4 pathology would suggest a recurrence risk as high as even 35% by 1 year out. So curative, but still a high risk for recurrent disease.
Now, if the patient has Child-Pugh B or C and would not have good residual liver function, this is when you can consider a liver transplant rather than surgical resection.
For patients who may not be surgical candidates or may have high-risk findings of imaging that are thought to be unlikely to benefit from surgery, this may be multiple tumors involving bilateral lobes of the liver or other possibilities that cause contraindication. That's when we tap into our interventional radiologist and radiation oncologist to approach with one of the many local regional techniques that are out there. Evidence comparing one to the other is near absent if present at all. The majority of these studies are single arm or retrospective studies. And in general, they seem to have similar benefits, which are, once again, these could be curative. However, the risk of recurrence can approach 50%. And as mentioned, prognosis is still measured in years, even for localized disease when treated locally. Due to the high risk of recurrence, especially after surgery, there's been a lot of interest and good rationale for considering adjuvant systemic therapy. There has been a lot of trials looking at this, most recently using our standard systemic therapies that we're going to get to in the advanced state, using drugs such as sorafenib or sunitinib, and more recently using immune checkpoint inhibitors. Time and again, giving systemic therapy after surgery has delayed time to disease recurrence, however, has never improved overall survival. And this is likely due to the fact that a good number of the recurrences can again be treated with local regional therapy, and we probably just don't have a good enough selection criteria to decide who are the most likely to have multifocal or distant relapse. And hopefully at some point we'll gain better insights on how to select patients for these adjuvant approaches.
So briefly to go over the local therapies that are available, and we won't go into too much detail on this because radiation oncology and interventional radiology are the ones that are administering these treatments. But some things that you might hear are TACE, which is transarterial chemoembolization. And basically what this does is it blocks the blood supply to the tumor and delivers localized chemotherapy. And due to that, if there's vascular invasion or a tumor thrombus, then this is not the preferred approach because you need to be able to get the chemotherapy to the tumor. But this can be used for larger tumors. One of the other techniques that you'll hear is radiofrequency ablation or microwave ablation. And this is best for smaller tumors less than 3 centimeters and fewer tumors such as 1 or 2.
Historically, alcohol ablation is another approach, although at least in the US, this is starting to follow a favor, and our preference would be for the other forms of ablation for the small tumors.
You'll also hear of Y90 radioembolization.
Y90 or yttrium-90 is a radioactive molecule. This is administered similar to TACE, where you may also hear this called as TARE, or transarterial radial embolization. So once again, interventional radiology procedure where we inject the compound quite locally, in this case with the idea of administering local radiation. This is becoming a much more popular approach. There's conflicting evidence on whether this is better than TACE. It is a more expensive and sometimes a bit more intensive approach to go, but at least at the centers that I've practiced at has been gaining in popularity, and I've certainly seen this used a lot more than TACE. But certainly, depending on where you work and whether or not this regimen is available, you may or may not see this used as the frequent approach to larger tumors. All three of these interventional radiology procedures are considered generally safe, although do have some toxicities, namely pain in the short term, as well as the potential for bleeding. And in the case of Y90, there's a reported but uncommon side effect of renal toxicity due to the Y90 itself being excreted through the kidneys.
And then lastly, SBRT done by radiation oncology is also another local regional approach.
An advantage rate SBRT has over the interventional radiology approaches is it is possible for SBRT to treat tumor thrombus within the portal vein. As with the interventional radiology approaches, though, randomized trials are lacking, and the best approach of which treatment to use when really does come down to expert consensus, further elucidating the importance of this being reviewed at multidisciplinary tumor boards focused on hepatocellular carcinoma.
So getting into systemic therapy, the first treatment in HCC that was found to show an overall survival benefit was sorafenib, which is a VEGF inhibitor. And this was shown in the SHARP trial, which was published in 2008 in the New England Journal. And this included around 600 patients with inoperable, so either metastatic or unresectable HCC. They had to have ECOG 2 or less, and the child's Pew score had to be A. So patients were randomized to sorafenib 400 milligrams twice a day versus placebo, and there was an overall survival benefit. The overall survival was 10.7 months versus 7.9 months. There's also an improvement in the time to radiologic progression, 5.5 months versus 2.8 months. However, the response rates were low. In the study, even in the sorafenib arm, only 2% of patients had a partial response, and no patients had a complete response.
In addition, this is not the easiest medication to tolerate. As mentioned, this is primarily a VEGF inhibitor, but sorafenib has many other targets, including RAF, PDGFR, generally considered to be a multi-targeted tyrosine kinase inhibitor. So toxicities are broad, like those that we've discussed with our VEGF inhibitors in the past, such as mucositis, hand-foot syndrome, diarrhea, hypertension, proteinuria, risk of bleeding and thrombosis are all very real risks. And in the case of diarrhea, 8% of patients had grade 3 or greater diarrhea. Furthermore, this was a very selected patient population. Many patients with advanced HCC do not have Child-Pugh disease, and this is also reflected in the number of patients that were screened and how many were ultimately randomized. 900 patients were screened, and only 600 ultimately were considered to be candidates to enroll in the trial. Fairly a large number of people excluded, either due to decompensating prior to enrolling on the trial or to not have adequate inclusion criteria. So a very big improvement for an otherwise difficult to treat disease, but did leave us wanting much better options, as well as an approach to patients with Child-Pugh or worse liver cirrhosis.
Now, after the SHARP trial published, pretty much every frontline trial has used sorafenib as the control arm. The next major study was looking at lenvatinib, which is another VEGF inhibitor, and compared this to sorafenib in the frontline setting. This was the REFLECT trial, and it was a non-inferiority study. Now, this looked at lenvatinib 12 milligrams daily for patients greater than 60 kilograms or 8 milligrams for patients less than 60 kilograms versus the traditional dosing of sorafenib 400 milligrams twice a day. The non-inferiority margin was 1.08, and this was met with a median overall survival of 13.6 months in the lenvatinib arm versus 12.3 months in the sorafenib arm for a hazard ratio of 0.92. There was a higher overall response rate with lenvatinib, 24% versus 9%, and also a longer time to progression, 7.4 months versus 3.7 months.
So these are both reasonable options in the first line setting. We'll say from clinical practice, giving these doses is not easy, and often we need to do pretty rapid dose de-escalation for either regimen. And many providers start to develop different ways of approaching giving these medications. And this is generally how we approach many of our tyrosine kinase inhibitors, including sunitinib, as we've discussed previously in the renal cell cancer space.
Now, lenvatinib has similar toxicities such as hypertension and hand-foot syndrome.
Mucositis, bleeding and thrombosis, and proteinuria are going to be seen in all of these agents. So although a number of TKIs were evaluated for hepatocellular carcinoma, there was not really a major improvement in overall survival until immune checkpoint inhibitors entered the space, and the first publication on this subject was in 2020. This was the EMBRAVE 150 trial, and this was a randomized controlled trial looking at patients who would either receive atezolizumab and bevacizumab, so a PD-L1 inhibitor combined with a specific VEGF inhibitor, bevacizumab, versus sorafenib. As with our sorafenib and other VEGF-related trials, there is a very strict inclusion criteria for the study. Patients could only have Child-Pugh disease. They couldn't have any risks or past history of bleeding or thrombosis. They couldn't be on any therapeutic anticoagulation. Also, the study had required all patients to have an upper endoscopy to rule out presence of varices, and this EGD had to be done within 6 months prior to treatment initiation. This study was powered for overall survival as a primary endpoint along with progression-free survival, and did primarily include patients who were hepatitis related. 50% of the patients had history or active HBV, 20% of the patients had a history or active HCV, and 30% of the patients had non-viral etiologies of their hepatocellular carcinoma. This is a positive trial, and the median overall survival is 19 versus 13 months. Worth noting that the control arm did better overall than in the SHARP trial we discussed previously, and this may reflect either patient selection or maybe as a reflection of better local regional approaches at the time of regional progression. When we look at the subgroups of the study, it did appear that the patients who did not have viral HCC did not have an added benefit, although there's limitations with subgroup analysis, so this is more of a hypothesis generating rather than practice informing finding. And the doublet, of course, did have some increased toxicity, namely with immune-related adverse events, but was generally well tolerated.
There was another trial incorporating immunotherapy into the treatment of HCC using 2 different immunotherapies, and this is the Himalaya trial, which looks at durvalumab, an anti-PD-L1 monoclonal antibody, and tremelimumab, CTLA-4 monoclonal antibody. And given that this doublet doesn't have a VEGF inhibitor, this could be an option for patients that aren't candidates for bevacizumab, such as patients with varices or history of clots or on anticoagulation. This study enrolled around 1,000 patients, all with Child-Pugh liver disease, all who had advanced or inoperable HCC. This study initially was started with 4 arms, looking at a single dose of tremelimumab, 300 milligrams, with durvalumab given every 4 weeks, versus the durvalumab alone, versus sorafenib, and then the last arm was the durvalumab every 4 weeks with the tremelimumab every 4 weeks, so not just the single dose of the tremelimumab. Now, that arm was shut down due to increased toxicities and similar efficacy as the just single dose tremelimumab, so the data is really reported on just the first 3 arms.
You may hear of the single dose of tremelimumab combined with durvalumab as the STRIDE regimen, STRIDE.
Now, the primary endpoint was the overall survival of the STRIDE regimen versus sorafenib, and this was significant, 16.4 months versus 13.8 months. However, interestingly, the progression-free survival was actually similar between both arms, 3.8 months versus 4.1 months.
The single-agent durvalumab arm was not part of the primary endpoint analysis. It did appear to be at least not inferior to the sorafenib. Median overall survival in the durvalumab arm was 16 months, so comparable by median to the STRIDE regimen. However, worth noting, when you look at the Kaplan-Meier curves, you see an earlier risk of death with durvalumab compared to either of the 2 other regimens. And past the median, there does appear to be a relatively reduced overall survival with just the single agent PD-L1 inhibitor. So although not statistically compared, at least visually, it does appear that the STRIDE regimen is superior, and durvalumab is somewhere in between STRIDE and sorafenib as a treatment option. As would be expected, giving a doublet immune checkpoint inhibitor blockade does increase toxicity, and grade 3 toxicity was approximately 50% in the STRIDE protocol versus 37% in the durvalumab arm versus 16% in the sorafenib arm. The investigators estimated approximately 12% grade 3 or greater immune-related adverse events in the STRIDE protocol versus 6% in the durvalumab alone arm. This risk of immune-related adverse events being reported does seem a bit lower than what we've seen in some of our other trials. Unlike the EMBRAVE trial, the subgroup of non-viral patients did seem to still benefit from the doublet immune therapy with improvements compared to sorafenib alone. Although it is worth noting that the definition of non-viral did include patients who were previously treated for HBV or HCV and did not have evidence of active hepatitis. So it's unclear how many of these non-viral patients still had a preceding viral etiology for their hepatocellular carcinoma. The reason I point out the subgroup of non-viral etiologies is relevant to at least my practice, where the majority of patients have non-alcoholic fatty liver disease or alcohol-related cirrhosis. And there have been meta-analyses, one of which was published in Nature, that showed in general patients receiving immune therapy for non-viral HCC have not typically shown benefits compared to our historic VEGF inhibitors. This is thought to possibly be indicated by differences in tumorigenesis. And it'd be useful moving forwards to have a better identification of biomarkers for selection of patients who are most likely to benefit from the more intensive immune therapy regimen. That being said, it would still be considered standard of care, if you have access to it, to either offer atezolizumab and bevacizumab or durvalumab and tremelimumab in someone who's being considered for systemic therapy. In patients with contraindications to immune checkpoint inhibition, such as those with a history of autoimmune disease, single-agent sorafenib and lenvatinib is still very much a reasonable option to consider.
For second-line therapy, there's no established sequencing data, so it really depends on what patients got in the front line as well as their comorbidities and performance status. If someone already had immunotherapy, there's no role for changing the immunotherapy or continuing the immunotherapy into second line. So this is when you'd want to reach for an alternate TKI, such as sorafenib, lenvatinib, regorafenib, cabozantinib, or ramucirumab. If immunotherapy wasn't used in the front line and the patient is a candidate for immunotherapy, you can consider single-agent pembrolizumab. There's also small trials of the combination of ipilimumab and nivolumab.
One point worth noting, although this is not necessarily practice informing but could be a high yield topic for board exams, would be ramucirumab. In the second line setting, this was initially compared to placebo and ultimately had a negative trial. However, in that initial study, a subgroup of patients with a very high AFP greater than 400, did seem to benefit. A subsequent randomized controlled trial has been run with ramucirumab versus best supportive care, and only patients with hepatocellular carcinoma with an AFP greater than 400. And in this trial, slight improvement in median overall survival is shown of approximately 1 month, and this did lead to approval by the FDA for this medication. Personally, I think choosing any of our VEGF inhibitors are likely going to be a reasonable option if someone's still a candidate for systemic therapy after first-line progression. And with the migration of atezolizumab and bevacizumab or durvalumab and tremelimumab, you're probably going to be reaching to either sorafenib, lenvatinib, or cabozantinib as your next line agent. But ramucirumab still could certainly be something that would show up in your practice depending on your preferences. Another thing always worth reconsidering is the role of local regional therapy, especially when you have a solitary hepatic lesion that's progressing with the remainder of systemic disease being under control.
I think it's time for some bottom lines. So HCC is the most common primary liver tumor, and risk factors are really anything that predisposes you to the development of cirrhosis. The most common being viral hepatitis, as well as non-alcoholic fatty liver disease and alcohol use.
This is a cancer with a major prevalence globally. However, depending on where in the world the cancer develops, you may see more of one etiology or the other. And depending on the underlying etiology, response to systemic therapies and overall prognosis may vary as well.
This is one of the cancers that you can actually diagnose without a biopsy, as long as the patient has risk factors for HCC, high AFP, and characteristic imaging features.
If a patient has been diagnosed with hepatocellular carcinoma and you have access to a transplant center or a center of excellence with a multidisciplinary group of specialists, the general approach should be to have these patients seen by a specialty center.
The preferred approach for resectable tumors would be surgical resection. However, there are other local options such as radiofrequency or microwave ablation, transcatheter chemoembolization, or Y90, or SBRT, done by either radiation oncology or interventional radiology.
Liver transplant may also be considered for either multifocal or decompensating liver disease, as long as there's no evidence of vascular invasion or extrahepatic tumors.
For unresectable tumors or patients that present with metastatic disease, frontline options include the combination of atezolizumab and bevacizumab, or the combination of durvalumab, tremelimumab, or you can start with the frontline TKI, such as single agent lenvatinib or sorafenib.
In some cases, durvalumab alone may be also considered. All of the clinical trial evidence that inform our care are patients with Child-Pugh A disease, although some retrospective studies have shown safety of giving these agents in Child-Pugh B disease. This would be considered off-label and should be administered with caution. In Child-Pugh C disease, there is no role for systemic therapy, and best supportive care would be recommended. For localized disease that's surgically resected or treated with a local regional approach, there has been interest in combining our novel effective systemic therapy options, and these have shown improvements in disease-free survival or progression-free survival. However, have yet to show overall survival, as many of the patients who recur can be retreated with some form of local regional management.
So thanks so much for listening, and congratulations to all the fellows who matched last week. Such an exciting time, and you picked the right career choice.
Thanks so much for listening, and we'll see you soon to move into our next discussion around glioblastoma.
Hopefully we'll have a new episode before the new year, but if not, happy holidays and happy new year.
Bye for now.
For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com.
Please rate and review the podcast. We really appreciate it.
And special shout out to our friend John Kim for all of his musical talents.
And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice.
For medical advice, please contact your own healthcare provider.
Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.